All right. Well, welcome back, everyone. We are ready to roll here for the second part of our conference. And we're going to have a presentation here by someone who is presenting on a topic near and dear to my heart. I am an educational psychologist by training, and we're going to be talking here about chronic illness and the impact on a patient's mental health. Such an important topic. We had a question in the Q&A about this. So yeah, definitely this is a topic that is important to all of us who have been diagnosed with vasculitis. So presenting here on this topic is Dr. Velma Mockett. Dr. Mockett provides therapy and counseling at Blink, a mental health company that provides essential therapeutic and wellness programs, trainings, workshops, and consultation to help employers, service providers, and individuals to improve mental health quality of life and well-being. Dr. Mockett helps guide individuals by exploring their feelings, thoughts, and behaviors and identify aspects of their life that they would like to change. Sessions can be done in person, via phone, video. And approaching counseling from a holistic perspective, Dr. Mockett's style is collaborative, dynamic, and client-focused. She believes that the problem is the problem and that clients have resilience capacities, some hidden, and can be an opportunity for growth and recovery. So without further ado, Dr. Mockett, we're delighted to have you here.
Thanks for having me. How is everyone doing? Well, thanks for having me. It is one of the things that people always ask about when you have vasculitis, like how do I cope? Is it something that everybody experiences? And then the answer is always like, yes, everybody experiences all the psychological things. So I think as someone that's newly diagnosed with vasculitis, it is very important to recognize that all the symptoms that you experience, the physical symptoms, and sometimes the side effect of the medication, all of those can impair your psychological well-being and your quality of life. So it's very important for newly diagnosed people to recognize that. Vasculitis causes a lot of psychological distress because it forces us to change our way, our routine, and our way of being as patients, and also as like your entire family as well. It changes the dynamic, the power dynamics in the relationships that you have with your spouse, with your children, because now you become the person that everybody have to take care of. So in a sense, I like to say it changes the plot. And when the plot has changed, then you have to sort of refocus on how you're going to look at developing certain skills to cope with that. So people, a lot of the clients that I speak with vasculitis, and myself included, people go through things like depression, anxiety, the deep sadness that people experience, grief. That is something that is not spoken about, that I have spoken about extensively, because there are tremendous losses that we experience when it comes to vasculitis: loss of job, loss of your friends, loss of functions, so many things. And so it's important to kind of think about grief. And grief is not just one emotion. It's a conglomerate of emotions that we experience when we're looking at grief. And so for everyone, it's going to look differently. So it's not a one size fits all. So it's important to also recognize that. So someone else may be experiencing anxiety while you may be experiencing depression. The impact that prednisone may have on one person, for example, may not be the same on a different person. So I had one person who spoke about having almost a psychotic breakdown with the impact of prednisone, and it took several doctors and a psychiatrist to recognize that, whereas other people may not have had that sort of experience. So it's important to recognize that while there are psychological distresses and it impacts the quality of life, for every one of you, it will look differently. Like for me, it looks differently than it does for maybe Sarah or for somebody else. So it's kind of thinking about that. But what we all have in common is that we do experience psychological distresses. And mental health is something that is not always talked about in illness. There's such a taboo with mental health. And it's one of the things in vasculitis research that I really hope we can begin to change in the next couple of years. It is not well researched, and so we don't know about it. But it's important to recognize that psychological difficulties are an integral part of sort of like the vasculitis sort of like process, and navigating that sort of like journey in vasculitis. It is something that is part of it. And another question people often ask me, am I crazy? The answer is no, you're not crazy. It is part of the journey. So it's not in your head. I had one person said to me, like, the doctor kept telling me it's in my head, but it's not in your head. You feel the things that you feel, and emotions are equal opportunity offenders. So imagine if people that are not sick experience depression and anxiety and all of those things. So imagine you having a disease that is ravaging through your body, that is changing the plot of your life, that you're experiencing things that you are not used to experiencing. So those things are kind of important to sort of recognize and to realize that you're not crazy. It is something that we all experience, and then we all have to work through it. So part of what I do sometimes is to just help people develop some coping strategies to kind of talk about grief, because we often think about grief as just being associated with death and dying. And so part of the issue is kind of talking about, what is your loss journey looking like? What are the things that you have lost, and how have you been grieving that process, so that you don't ignore that? Because we have depression that come underneath the grief sort of like conglomerate of emotions, and sometimes some doctors and other even therapists can sort of like mix that up for just clinical depression, whereas if you work through grief, you may find that those things will go away. So it's been able to also distinguish between depression that comes with grief and clinical depression. So all of those kinds of things are, things that we do experience. And mental health is important. It's one of those things that we ignore, but it's very important. Without mental health, we don't have good quality of life. And vasculitis is already changing the plot, which means that it's changing certain things in terms of your quality of life. So it's important to take care of your mental health, to do things like mindfulness practices, to go for walks, talk to a friend, recognizing that the fatigue that comes with vasculitis can sometimes have tremendous stress for people. So do a lot of stress management, and all of those kinds of things will help in sort of navigating, vasculitis. Vasculitis, I like to call myself a construction zone, which means that I'm always learning something. There's always something that needs to be changed. There's always something that's being worked on, and nothing is ever complete with vasculitis. When you fix something, something else is happening. So it's building that sort of like resilience capacity so that you're able to absorb, but not only absorb, that you can, because when we absorb, we think we always have to sort of go bounce back. But resilience is also about bouncing forward. So how do we transform? How do we adapt as vasculitis begin to evolve in our life? So all of those kinds of things are important things to kind of think about.
Fantastic. Yeah, Dr. Mockett, I think you nailed it. I think the thing that stuck with me in your presentation is that getting a diagnosis is definitely a plot twist. It is one big plot twist in life. And I mean, one of the things that I've experienced, and I think that you can definitely speak to this, is that because vasculitis is a systemic disease, it's also very much a systemic disease in your life. So, it touches on all these different systemic things in your body, but it also touches on all of those different things that affect your mental health systemically as well. So, absolutely. So
it's important to learn all of those kinds of strategies to work through. Like I was talking to someone last week from Ontario, and they said to me, well, I feel tired. And then one of my friends has been telling me I need to have a walking plan. Well, no, you can't have a walking plan every day. But what you can do to help you through the fatigue and also through the joint pain and things like that is learn a restorative movement. So you may want to move your body every day, but it doesn't mean that you have to go for a walk every day. You want to learn different restorative type of movement so that you can sort of help your body sort of like deal with some of those kinds of things. So what I do is I do a lot of kinesiology type exercises that are very slow and very easy on the body. So I do about 15 to 20 minutes of that every day. So I'm moving my body every day, but it doesn't mean that I'm going for aggressive walks or going to the gym and things like that. So it's learning those different kinds of ways to help you while you're sort of navigating that journey, because it's a difficult journey. And for vasculitis, grief doesn't stop, because every month, every year, every time you get an attack, you're losing something different. You may lose this friend today, another friend next month. You may lose your job. You may lose so many different things, even your partner sometimes. You never know. So many things can change. So you have to sort of learn to adapt and learn to transform it. So it's a journey that doesn't stop. There's no end to grieving when it comes to vasculitis. And that's one thing I think that have to be kind of that we have to talk about. We don't talk about it.
Yeah, absolutely. Well, I invite you to hang out on our Q&A and our chat session. And if anyone has any particular questions that they'd like to address to Dr. Mockett, wow, that's probably the best platform that we can use at this point. So Dr. Mockett, I invite you to check out the Q&A and the chat session there. And I invite all the participants to ask any questions that you may have at this point. So Thank you. Thank you so much for coming, and we appreciate your presentation here.
Thanks, you're welcome. Thanks for inviting me. I do appreciate that.
Sure. So moving on to a topic that I'm sure all of you are looking forward to learning a little bit more about. We have here a presentation on medications, Medications 101. So everything that you need to know about medications, coming from Dr. Anisha Dua. Dr. Dua is the director of the Northwestern Vasculitis Center and director of the Rheumatology Fellowship Program at Northwestern University. She leads a multidisciplinary team in the clinical management of vasculitis patients and is expanding clinical and translational research initiatives at Northwestern. She recently assisted in the development of the American College of Rheumatology/Vasculitis Foundation guidelines for the treatment and management of vasculitis. She has served in leadership roles locally and nationally within the American College of Rheumatology and the Vasculitis Foundation. So welcome, Dr. Dua. We're delighted to have you here.
Thank you, Sarah, for that extensive introduction. It's nice to have all of you guys here. I know this is a difficult topic to cover all of the medications, obviously, in vasculitis. And when you get this new diagnosis, there are so many terms being thrown at you, so many abbreviations, so much information, and it's like drinking, water from a fire hose type of feeling. I'm going to try to break some of these down and go through different medicines, but I do want to just point out what Dr. Mockett was talking about. We can treat certain things with medications, but other parts of your disease are like your body and your mind are very, very much connected. And it's really hard to heal one without really focusing on both. So it's just, we do what we can with the medicines, and I'll try to demystify some of them, but it's really about the whole person. So let's see. These are my objectives. It's basically to go over some of the medications that are used in the treatment of vasculitides, talk about some of the toxicities and be aware of them and how to minimize the risk of developing them. Again, I don't want this to sound like one of those scary commercials with a laundry list of side effects and potential stuff, but I do want you guys to be aware of the things that may occur with some of the medicines we're using. So I can't go through every medicine, but these are the ones that I sort of picked out that are used in a lot of the vasculitides. So these are the ones I'm going to focus on. So we'll start with a case. A 55-year-old male presents to the ER with fevers, trouble breathing. He's coughing up some blood and he has leg swelling. We get some blood tests. The labs show anemia and elevated creatinine, which is worsened kidney function. His urine has 4 grams of protein in blood. His C-ANCA titers are positive with a PR3, and his infectious workup is negative. He gets a CT scan of his chest, shows nodular lesions. We get a kidney biopsy, and it shows granulomas and vasculitis in the kidneys. So this is a pretty severe classic presentation of a patient with granulomatosis with polyangiitis. So what are our goals here when we know what's going on and what do we do? So the first part is getting the diagnosis, and the next step is figuring out what we can do, right? So I think our goals are really to prevent inflammation is our first thing. And our second thing is once we get that inflammation under control, minimize damage and prevent relapses. And that's what we're trying to do with the different medications. So I split it up when I'm talking to my patients into 2 phases. There's induction, which I think of as trying to put out the fire that's attacking the blood vessels. And then I think about maintenance, which is basically keeping out the fire without causing a flood. And there's different medicines, like I said, that you use in each of those categories. And in this case, some of the options for induction would be cyclophosphamide or Rituximab. Rarely in limited GPA, you can use Methotrexate. And then for maintenance, you can use Rituximab, Azathioprine, occasionally mycophenolate and Methotrexate. I'm going to talk about some of these meds, like I said, moving forward. So we'll start with cyclophosphamide. Cyclophosphamide and prednisone were basically introduced in the treatment of ANCA vasculitis in the 60s and 70s, and one of the seminal papers was from Fauci. And it really transformed ANCA vasculitis from a fatal disease to really a chronic relapsing disease. It's very effective in getting patients into remission. You can see 93%, but half of the patients suffered side effects, and those include cystitis, infertility, bladder cancer, lymphoma, infections. And also, importantly, half of them, even though they were able to get into remission, had a relapse within 5 years. So again, it was initially used as part of chemotherapeutic regimens, but then we found that it was effective in rheumatic diseases. And it's used in many organ and life-threatening vasculitides, including ANCA vasculitis, polyarteritis nodosa, cryoglobulinemic vasculitis, and Takayasu's. Now with cyclophosphamide, the increase in your cumulative dose, so the more that you use over time, the higher risk you have of a lot of these toxicities. And it used to be that we really had Cytoxan as our main option. So we had to use it really long-term for years and years to keep people in remission. But now we usually use it upfront to induce remission for 3 to 6 months and then switch. So that does decrease the amount of toxicities that our patients are experiencing these days with this drug. Some of the major concerns we think about are bone marrow suppression. So we're following your blood counts regularly, and we may adjust the dose based on that white blood cell count. Gonadal toxicity, this is something you want to talk about if you're of childbearing age, thinking about either sperm banking or talking about egg preservation with the appropriate healthcare providers in case that's something that needs to be done. Infections, of course, all of these diseases, because we're trying to manipulate the immune system to stop attacking the blood vessels, can put you at higher risk of different types of infections. So things that we look at are your neutrophil levels. Like I said, we're monitoring your blood counts regularly. We'll put people often on PJP prophylaxis with Bactrim, and that's to try to prevent a type of kind of dangerous pneumonia. And then, we want to get your vaccinations as soon as you can before being on these medications if possible. Another toxicity that we always talk about with our patients is hemorrhagic cystitis or bladder cancer. Again, this is really at a higher risk when you have high doses, up to like 50 to 100 grams. And this is because one of the metabolites of cyclophosphamide is acrolein, and that is toxic to the bladder. We try to prevent this by giving Mesna in the IV fluids when you're getting it through the IV, and tons of hydration. So whenever you're on Cytoxan, make sure you're staying really hydrated with water. And then malignancy. So there is an increased risk of leukemia, skin cancers, and other malignancies. But again, the duration of the time that you're on Cytoxan and the cumulative dose is what will sort of contribute to that risk. It's important to note, I'm mentioning doses of 50 to 100 grams. And in a large retrospective study of cyclophosphamide in patients with rheumatic disease, the median dose was 9 grams. So that is a lot less than some of these scary doses with some of these outcomes, but it's still important to screen for all of this. Okay, so how about Rituximab? That was the other one that I mentioned in terms of induction in this case. Rituximab was approved to treat malignancies in 1997, rheumatoid arthritis in 2006, and then we got it approved for MPA and GPA vasculitis in 2011 for induction. And it was now approved for maintenance in 2018. We also use it in lupus, cryoglobulinemia, Henoch-Schönlein purpura, and it works basically by binding to CD20 on B cells, right? And B cells are part of our immune system that make antibodies such as ANCAs. So by binding to these B cells and sort of disrupting their progression, we decrease the antibody load, and we can sort of, again, manipulate the immune system to try to help shut down the vasculitis. The dosing, the induction can either be weight-based dosing, so weekly doses for 4 weeks, or you can get 1 gram on day 0 and day 14. And then when you switch over to the maintenance phase, it's usually between 500 to 1,000 milligrams every 4 to 6 months, and that'll be sort of determined by your physician and your manifestations. Common infusion reactions, this is given through the IV, are itching, some nausea, vomiting, dizziness. You can get some headaches, low-grade fevers during the infusion. To try to prevent that, we pre-medicate with Tylenol, Benadryl, steroids. If you're having some of those symptoms, you're in an infusion center, they'll slow down the rate and sort of titrate it back up to make sure you're tolerating it okay. Some infusion reactions can be severe. And if you have any sensations of throat closing or anything like that, difficulty breathing, you need to tell them. And that usually happens with that first infusion. It's 80% of the time, if you're going to have this severe infusion, it's going to be with that first one. So that's when you're going to be most cognizant of it. Other concerning side effects, again, infections. We're monitoring for late onset neutropenia and low gamma globulins. Like I mentioned, it attacks it shuts down or manipulates the B cells. B cells are also important in making our immunoglobulins that help us fight infections. So we're trying to monitor, are we doing a good job of controlling the vasculitis, but we might be putting people at increased risk of having trouble fighting some of those infections. One that's scary that patients ask about is progressive multifocal leukoencephalopathy. This is exceedingly rare. It is caused by a virus called the JC virus, which is positive in 92% of the population. So there's really no utility in checking if you have this virus before starting the drug. But it is a neurodegenerative disease, and so it can be worrisome. As of November 2018, there were only 2 confirmed PML cases among patients who had received Rituximab for GPA. Again, it's not really associated with a certain time frame. More infusions don't put you at more risk of this or anything like that. So some tests that we check before or during treatment with Rituximab include a hepatitis panel and a TB test, because there's increased risk of reactivation of hepatitis B. Some docs will monitor your lymphocyte subset count and be checking what's called a CD19 level. That's basically telling us, is the rituximab kind of coming out of your system, and are your B cells becoming more active again? We'll be following your blood counts really closely. As I mentioned, your white blood cell count, your neutrophil levels, quantitative immunoglobulins. Some folks will check ANCA titers. Not all docs will do that, just to help guide us with when we want to redose. And then again, you want to get your vaccines up to date, ideally prior to the infusion. So if you're spaced out every 6 months, you want to get it right before your next infusion if you can, because that's when you have the best ability to mount a response to that vaccine. All right, so we've covered rituximab and cyclophosphamide. I'm going to go on to some oral medications, and we'll talk about methotrexate and azathioprine. So back to our patient who was treated with pulse steroids and IV Cytoxan in the hospital. He did well. He had renal recovery, and his new baseline creatinine is 2.2. He's got some low levels of protein in his urine, but he's doing pretty well. His ANCA titers are now undetectable, and he follows up with you in clinic. He wants to know what are the next steps after he takes this cyclophosphamide for 3 to 6 months. So 2 of the options are azathioprine and methotrexate. The WEGEN trial was a prospective trial where they compared methotrexate to azathioprine after induction with IV Cytoxan. You can see they stopped the maintenance therapy after a year, and after that, relapse rate was about the same in both of these groups. So methotrexate wasn't safer than azathioprine in terms of side effects. They both were equally effective in keeping people in remission. And the fact that you see that people were flaring after that 1 year when the maintenance therapy was discontinued highlights the importance of sort of longer term use of these medications for maintenance therapy. So we definitely recommend being on some sort of maintenance therapy for at least 2, if not 5 years. And again, that's something that would be discussed with your treating physician. Oh, sorry. So azathioprine, that's the other one that, it was shown actually in the Cyclophosphamide trial to be as effective as cyclophosphamide. This was really a game changer. Like I mentioned, cyclophosphamide had to be used basically, period, for induction and maintenance. And we know all those nasty side effects. So this was really the first drug that was shown to be as effective for maintenance. So it replaced cyclophosphamide as a long-term maintenance therapy. More recently, we saw that Rituximab is really effective. So a lot of folks will be on Rituximab for their maintenance. But up until 2018, when that was approved, we were using a lot of azathioprine. It was first used for kidney transplants by the British in the 1960s or earlier. We also use this medication in inflammatory bowel disease, rheumatoid arthritis, lupus, Takayasu's, polyarteritis nodosa, cutaneous vasculitis. It works by inhibiting purine metabolism, so it has an effect on DNA synthesis, and it really targets T cell death more than your B cells. Some docs will check what's called the TPMT enzyme prior to starting this medication. Again, it's questionable because if it's one of the enzymes that's used in processing or metabolizing azathioprine, and if people are very deficient in it, it can increase the likelihood of having a drop in your white blood cell counts after starting the drug. Another option is really just starting with 1 tablet a day, which is 50 milligrams, and monitoring your blood counts closely as you titrate to a goal dose. And in most folks, the goal dose is going to be about 100 or 150 milligrams, so 2 or 3 tablets a day. Adverse effects for azathioprine, the common stuff is, it's a pill, right? So nausea, vomiting, some GI upset. Sometimes if you just kind of can fight through it, your body will get used to it and you don't have those side effects anymore. So if it's tolerable, I would say try to stick with it. Occasionally people can get a skin rash and some muscle soreness, but the serious things that we're going to be looking out for are bone marrow suppression. Like I said, that drop in the white blood cell count. So as we're titrating the dose of this medicine, we're checking your CBC regularly. And then even once you're doing well on it, we're still going to be checking your labs every 3 months or so. Pancreatitis can happen. It's rare, but I've had patients who develop pancreatitis from this medication. It can be liver toxic. It doesn't progress to cirrhosis. We just have to follow your liver enzymes. And then skin cancers, squamous cell cancer is a risk, and photosensitivity. Again, infections are across the board an issue with our immunosuppressive drugs. An important thing to note, if you have gout and you're on allopurinol, this can have a significant interaction with azathioprine and the dose will be reduced. This is something your physician should catch and notice, but it's just something that I want to mention because a lot of people are on allopurinol. Also, captopril or enalapril for your blood pressure. If you're on one of those medications, it can sort of drop your blood counts a little bit more, so you want to just keep an eye on them, or your doc should. And then moving on to methotrexate. Methotrexate's been used in multiple disease states. As rheumatologists, we love this drug. It was historically used with malignancies, but we use it in rheumatoid arthritis, scleroderma, vasculitis, lupus, long list. The doses that we use for our diseases are much lower than those that are used in malignancy. So we're usually using about 7.5 to 25 milligrams weekly. So in terms of pills, each pill is 2.5 milligrams, so up to 10 tablets, or we can do it subcutaneously as well, versus the 1 gram cycle. So that's a lot more that's used when we're talking about chemotherapeutic regimens. So when you're looking up the drug, you might see side effects, but again, the dosing really does matter in terms of what people are going to be feeling. Common toxicities are GI upset, nausea, stomach ache, loose stools. You can use ranitidine or like a PPI, you know, a omeprazole or something like that before the dose to try to decrease some of that nausea. A lot of folks will complain of like fatigue, headaches, and just feeling kind of crummy. And that usually happens about 24 to 48 hours after the dose. If it's intolerable, talk with your doc and see what else can be done. Other sort of rare but possible side effects include alopecia, so hair loss. It's usually not dose related. Stomatitis, so you can get sores in your mouth, and that's more common at the higher doses. And to try to prevent some of these, we give patients folic acid, 1 milligram a day as a standard, but you can actually increase that up to 5 milligrams a day, or even consider leucovorin, which is like a heavy duty folinic acid, which is like folic acid. And that's just taken once a week right after the methotrexate dose or the day of the methotrexate. Other things that we're watching for are abnormal liver enzymes or low blood counts. So again, if we see some of these things changing, we may say, let's pull back on the dose or hold your dose for a little bit. You want to avoid heavy alcohol use. It's processed through the liver. And then we screen for hepatitis prior to starting methotrexate. And then again, we don't use this drug much in patients who have sort of chronic kidney disease because it is, you can get worse low blood cell counts with renal impairment. So we don't use this in patients who have kidney involvement of their vasculitis or chronic renal disease for different reasons. You can get a pulmonary toxicity. Again, if you have some shortness of breath or issues at baseline, we would get a chest x-ray, and we would avoid this drug if there's any signs of interstitial lung disease. And then again, very important, if you're of childbearing age, you want to use 2 types of contraception if you're on this drug, and stop therapy at least 3 months prior to conceiving. So this is toxic to the fetus and can induce miscarriages. Again, infections is going to be on every list here. So now we're going to go on to Tocilizumab. Again, I'm going to go back to a case just to try to ground it. So this is a 75-year-old female with 3 weeks of new onset right-sided headache. She's got malaise, shoulder and hip girdle pain. She's had a 12-pound weight loss over the past 2 months. She's kind of stiff when she wakes up in the morning for 2 to 3 hours. She notes that she's having trouble getting out of the chair, combing her hair because of pain, and she's had some recent onset of jaw pain when she's eating. She did complain of a transient episode of vision loss in the right eye, but it resolved after a few minutes. So diagnostically, what we're going to do is either a temporal artery biopsy or a temporal artery ultrasound to try to figure out if there's vasculitis, check her inflammatory markers, and in this case, we're going to treat her for presumed giant cell arteritis. You could consider IV steroids given her episode of vision loss, but you're going to be using pretty high dose steroids, usually a mg per kilogram per day. And I'm not going to talk about steroids because Dr. Kermani is going to be talking about that after my talk. But she has longstanding diabetes, and you want to start another agent. You want to start Tocilizumab. This is approved. Tocilizumab works by inhibiting the effects of a protein essentially called interleukin-6. We've been using this in rheumatology for rheumatoid arthritis since 2010, but it was approved for giant cell arteritis as a subcutaneous weekly injection in 2017. There are also IV dosings for this medication, but the trials use the subcutaneous dosing. IL-6 is a really strong inflammatory, like I said, cytokine or protein that can have effects throughout the body, including basically inflammation in your liver, in fevers, in your blood counts and everything. So this drug basically works by blocking IL-6 so basically it blocks the receptor so that IL-6 can't bind and you don't get those downstream effects. This was the major trial that looked at Tocilizumab in giant cell arteritis. And they basically, up until this point, we were just using steroids, period, for this disease. Sometimes we would try methotrexate, but it was really tough to get patients, because it's usually an elderly population and there's so many side effects with steroids. And so this was really a breakthrough. What they did in this trial was look at Tocilizumab weekly versus every 2 weeks. And then they did sort of a fast prednisone taper at 26 weeks, and then a prolonged one over a year, which is more classic to what we were doing in practice. And basically the patients who were on Tocilizumab just did better. They had less relapses. They needed lower cumulative steroid doses. And importantly, they had meaningful improvements in SF36, which is a patient-reported outcome measure in terms of how they're feeling and functioning from a mental and physical standpoint, and also fatigue scores compared to the group that was on prednisone only. So overall better quality of life. It's also used in refractory Takayasu, just as a side note. Some of the precautions with tocilizumab, you want to use caution if a patient has diverticulitis, because there's an increased risk of GI perforation. Herpes zoster reactivation, again, you want to get all of your vaccinations as soon as you can, ideally prior to starting these meds. Cholesterol issues, so we're watching your cholesterol when you're on this medication, and we don't really recommend it for those who have liver disease. Also, we don't want to start in patients who have a really low specific white blood cell count of neutropenia. So as we're monitoring you on this medication, we're going to be looking for, of course, signs of infection. We're screening for TB prior to starting the drug. And then we're going to be checking your blood counts with the differential, your liver enzymes prior to starting the medicine, and then every 3 months during therapy. And then we're also going to check your cholesterol before we start the medication. And then, every 6 months when you're on long-term treatment. The question is, but if it may be that your lipid panel will get worse, but then we usually have to add other medications to try to get that under control if this drug is working for you. So that's tocilizumab, and then I'm just going to wrap up with this last medication here, Mepolizumab. So what's Mepolizumab? It is a medication. So IL-5 is another cytokine or inflammatory protein, but it regulates the growth, activation, and survival of a type of white blood cell called an eosinophil. Eosinophils are really, really important in the pathogenesis of something like EGPA, or eosinophilic granulomatosis with polyangiitis. So we see increased levels of this in EGPA, and it's associated with disease activity. So Mepolizumab is used in severe eosinophilic asthma, and it was approved for relapsing or refractory EGPA as an add-on therapy in 2017. What it does is, down here it's labeled Nucala. It basically blocks IL-5 so it can't bind to its receptor on the eosinophil, and then the eosinophil doesn't get to mature and propagate and cause the damage that's going on in the blood vessels. There are other agents that are being looked at, some that block IL-5 specifically and some that block the receptor, kind of also trying to target this disease state. This was the breakthrough landmark trial called the MIRA trial. It had 136 relapsing or refractory EGPA patients. They were randomized to either Mepolizumab, 300 milligrams every month, plus standard of care, or placebo, and they were followed for a year. And what they found was that the patients who got Mepolizumab more of them were able to achieve remission, and then they had more time in that year period where they were maintained in remission. They had less relapses, and they had a lower steroid dose. So again, this was a very stringent definition for remission. So it was less than 4 milligrams a day, and only about half of the patients were able to achieve that. But if you were a little looser with your prednisone dose to 7.5, a lot more patients with Mepolizumab were able to do well and not have relapses. In terms of safety, it's a very targeted drug. Like I said, it targets that IL-5. So it's usually pretty well tolerated, but some patients can complain of headaches, injection site reactions, and arthralgias, or just fatigue. It tends to work especially well in upper respiratory or rhinosinusitis type symptoms, basically what we consider the eosinophilic manifestations of the disease. And it works especially well in patients who have elevated eosinophil counts at baseline. So those are the medications I kind of wanted to touch on. Again, there are a lot of scary sounding side effects, and when you read the list or you listen to the commercials, it can really be overwhelming. It's important to bring up the things that matter to you. And what freaks you out about the medicine, whether you're taking it or not, because we can't treat you unless we really know honestly what you're taking medically, and then also outside of that, what herbal supplements are you taking? What else are you doing? Because that they interact with some of our meds, so we need to know. Just being straightforward and honest with your provider, so we can figure out the best ways to move forward and help you, because different things are going to scare different patients, right? And so when we know what it is that worries you, we can figure out what's going to be the best drug that's effective, but that can sort of help you live your best life. So the side effects for medications-induced infection, here are some pictures of areas that can be affected by the medications. And these are signs of vasculitis. So another issue is that it can be really hard to tease out sometimes active vasculitis or progression of your vasculitis compared with some of the side effects of the medications that we're using to even treat it. So again, there can be overlap between disease manifestations that can make this management complicated. So just be, like I said, communication is key. With an increased understanding of these diseases, we've been able to develop new drugs that are much more targeted with less of those toxic side effects. And this helps us minimize these risks and toxicity, but that does come at a cost. Part of that cost is pricing, so actual cost. And part of that is we have less data, right? These are newer drugs, so we don't have a lot of data on some of the long-term toxicity. So drugs that we've been using for ages, while they may be a little dirtier in terms of their side effect profile, we know what it is. We've been using these for a long time. So there's different ways to look at it. Many current trials, a question that I always get right when someone gets a diagnosis is, when can I stop the drugs? And, of course, this is a stepwise process, and it's tough. I know the first thing you want to do is, when can I be back to normal, right? And it's hard for everyone, to get to, guess on that or put a time frame on, because it's really about just maximizing and making your everyday the best that day can be. And, I understand that patients really want to get off of these medicines for all the reasons I just mentioned in the last 25 minutes. But there are trials where we're trying to figure out, how can we safely pull down these medicines? When is the best time to pull off based on certain disease state, maybe blood tests? What are some markers that can show us it's really safe to pull this back? Again, we're trying to put out the fire, but not cause a flood. And we're trying to learn a little bit more about when we can minimize or stop those medications. So we want to get to know our enemy, which is the vasculitis. We want to choose our weapons and make them as targeted as possible, prevent some of the awful side effects I just talked about. That'll make you happy and us happy, and will help us not over-medicate, but get your disease under control. And that's it for me.
Great. Well, Dr. Dua, thank you so much. That was extremely comprehensive, and thank you. If you don't mind, we have a couple of questions that are coming off the Q&A regarding Rituximab that maybe you could just touch on, and if you wanted to view them in the Q&A and maybe elaborate on them if you feel like you need to. But one question I think is kind of important here. How many years can a patient take Rituximab if you're taking it every 6 months for maintenance? What's kind of the general thinking around that?
Well, so there's not a cutoff date, like I said, there's not a day where we say you can't get any more. It's really more based on whether you're tolerating it. If you're getting repeat infections, if you're having infusion reactions, we're going to try to minimize this or end it sooner. There's also certain, someone's PR3 positive or has at higher risk of relapses and has had relapses in the past. So different markers that let us know that we think you're kind of at higher risk, or severe organ involvement when you first were diagnosed. All of those things are going to make us try to continue the Rituximab longer. Recently, out of France, there was a maintenance trial looking at, can we stop after 2 years, or do we really need to continue for 5 years? And, not surprisingly, the patients who stopped after 2 years had more flares than the patients who were continued for 5 years. So, I think it's really hard to get things back under control. So I'm a little bit more conservative. I usually treat for longer as long as the person's tolerating it. But again, if somebody has been doing well, has had sort of mild disease and hasn't had any flare-ups and doesn't have a lot of risk factors for relapse, I might start spacing out, maybe dose reducing, things like that at the 2-year mark, and seeing when I can, how little I can get away with in terms of the detox.
Yeah, I mean, and I think that touches on the other question here, which was what criteria are used to decide between the maintenance at 4 months versus 6 months. And I think you kind of touched on that a bit. Yeah,
so 4 months or 6 months, 500 milligrams or 1,000 milligrams. It's all what's been done in different trials. So just based on the different trials, those were the regimens that were used. And so, it depends on each patient, how you tolerate it, what your blood counts are looking like, whether or not you have pretty severe organ involvement, or whether it's, not quite as severe, not life-threatening. Those are going to be things that'll help us figure out what dosing to use.
Great. Well, thank you so much, Dr. Dua. We appreciate your expertise in this. Thank you so much for your presentation.
No problem. Nice seeing all of you guys.